Welcome to This Week in Oncology. This week we are covering 4 notable papers spanning novel therapeutic boundaries in thoracic oncology, the limits of aggressive regional interventions in gastric cancer, and the evolving systemic landscape of advanced prostate cancer. Let's dive in. We begin in the realm of thoracic oncology, where 2 newly published studies challenge conventional treatment paradigms, one by refining adjuvant therapy in early to locally advanced disease, and the other by exploring a radical surgical option for advanced refractory illness. First, in the adjuvant setting, we look at the Phase 3 ELEVATE trial, which evaluated the second-generation anaplastic lymphoma kinase, or ALK, inhibitor Ensartinib in patients with completely resected ALK-positive stage 1B to 3B non-small cell lung cancer. Historically, while ALK inhibitors have transformed the management of metastatic disease, their role in early-stage resectable disease continues to expand. In this double-blind, randomized trial, 274 patients who had completed completely resected disease and subsequent adjuvant chemotherapy were randomized in a 1-to-1 ratio to receive either Ensartinib at a dose of 225 milligrams once daily or a placebo for 24 months. The primary endpoint of the trial was disease-free survival in patients with stage 2 to 3B disease, while the key secondary endpoint was disease-free survival in the overall patient population. The results were striking. At 24 months, the percentage of patients with stage 2 to 3B disease who were alive and disease-free was 86.4% in the Ensartinib group, compared to just 53.5% in the placebo group. This represents an 80% reduction in the risk of disease recurrence or death, which was highly statistically significant. Across the overall patient population, which included those with stage 1B disease, the disease-free survival rate remained highly consistent, with 87.3% of patients in the Ensartinib group alive and disease-free compared to 57.2% in the placebo group. While the overall survival data are currently immature, clinicians must carefully weigh this efficacy against the therapy's safety profile. Grade 3 or higher adverse events occurred in 35.8% of the patients who received Ensartinib, with skin rash being the most commonly reported toxicity, compared to 18.2% of those who received a placebo. Nevertheless, these findings firmly support the integration of targeted ALK inhibition into the adjuvant algorithm for resected ALK-positive non-small cell lung cancer, providing a highly effective option to delay recurrence. Transitioning from early-stage targeted therapy to the extreme end of advanced disease, a prospective study published in JAMA explores a highly controversial and historically avoided intervention: lung transplantation for patients with medically refractory, lung-limited, stage 4 non-small cell lung cancer. Typically, stage 4 lung cancer is considered an absolute contraindication for transplantation due to the high risk of rapid recurrence under post-transplant immunosuppression. However, patients with disease strictly confined to the lungs often die of progressive respiratory failure rather than systemic metastasis. To address this clinical dilemma, researchers conducted a prospective, single-center registry study involving 98 adults with medically refractory, lung-limited, stage 4 non-small cell lung cancer. Of these, 17 patients underwent lung transplantation using contemporary staging and a specialized dissemination-minimizing operative technique, while 81 patients who met transplant eligibility criteria but did not undergo the procedure due to non-biologic barriers were treated with medical management alone. The outcomes of these 2 cohorts were also compared to over 300 adults without cancer who underwent lung transplantation for end-stage pulmonary disease during the same study period. The survival difference between the transplant and medical management cohorts was profound. The Kaplan-Meier estimated 1-year overall survival was 100%, with 0 deaths among the lung transplant recipients with non-small cell lung cancer, compared to just 40.8%, representing 52 deaths among those who received medical management alone. This represents an absolute survival difference of 59.2 percentage points. Furthermore, when evaluating organ stewardship, the 1-year post-transplant survival was 100% among patients with non-small cell lung cancer, compared to 88.1% among patients without cancer who underwent transplantation. At the extended follow-up, only 2 of the transplant recipients with stage 4 non-small cell lung cancer had died. While the single-center registry study is small and requires longer-term follow-up and comprehensive quality-of-life assessments, it suggests that for a highly selected subset of patients with lung-limited refractory terminal disease, lung transplantation may offer a viable, life-prolonging option. We turn next to gastrointestinal oncology, where a highly anticipated clinical trial reminds us that more aggressive local regional treatment is not always superior to systemic therapy alone. Writing in The Lancet Oncology, researchers presented the final results of the Periscope 2 trial, a European, multi-center, randomized, controlled, Phase 3 study evaluating the utility of gastrectomy, cytoreductive surgery, and hyperthermic intraperitoneal chemotherapy, or HIPEC, for patients with gastric cancer and limited peritoneal metastases. Peritoneal dissemination has historically carried a dismal prognosis, and while cytoreductive surgery and HIPEC have been widely adopted in some specialized centers, rigorous randomized evidence comparing this approach directly to systemic therapy has been lacking. This trial, conducted across 8 European tertiary referral hospitals, recruited adults with resectable stage T3 or T4, a gastric adenocarcinoma, who had limited peritoneal metastases, defined as a peritoneal cancer index of less than 7, or tumor-positive peritoneal cytology, or both, in the absence of disease progression after 3 or more cycles of systemic therapy. 102 participants were randomly allocated in a 1-to-1 ratio to the standard group, which continued systemic therapy, or the experimental group, which underwent gastrectomy plus cytoreductive surgery, and HIPEC, with oxaliplatin administered at 460 mg per square meter at 41 degrees Celsius, and docetaxel at 50 mg per square meter at 37 degrees Celsius. The trial was closed prematurely due to an unplanned interim analysis for futility. Over a median follow-up of 67 months, the primary endpoint of overall survival showed no benefit from the aggressive surgical approach. The median overall survival was 16.6 months in the standard systemic therapy group, compared to 15.7 months in the experimental surgery and HIPEC group, representing a non-significant hazard ratio of 1.10. Crucially, the experimental arm carried a far heavier burden of toxicity. Grade 3 or worse adverse events occurred in 42% of patients in the experimental group, compared to 20% in the standard group. The most common grade 3 or worse adverse events in the experimental group were anemia and elevated liver enzymes, each occurring in 8% of patients, while the standard group experienced low rates of nausea, elevated liver enzymes, and electrolyte disturbances. Serious adverse events were vastly more frequent in the surgical arm, affecting 44% of patients, compared to only 6% in the standard arm. Most concerningly, 3 treatment-related deaths occurred within 100 days of randomization, all in the experimental group, resulting from acute respiratory distress syndrome, anastomotic leakage, and hemorrhage. These findings deliver a clear clinical message. For patients with gastric cancer and limited peritoneal metastases, the addition of gastrectomy, cytoreductive surgery, and HIPEC does not prolong life, but significantly increases the risk of severe complications and mortality. Standard systemic therapy remains the appropriate backbone of care. Finally, we turn to a comprehensive review. Over the last 2 decades, the management of this disease has undergone a dramatic transformation, driven by advanced imaging, genomic profiling, and the introduction of highly effective systemic agents. The authors highlight that the key to improving long-term outcomes has been the earlier deployment of potent therapies. Specifically, the use of androgen receptor pathway inhibitors has now moved upstream, establishing a firm role in both high-risk biochemical recurrence and metastatic hormone-sensitive prostate cancer. As patients transition to metastatic castration-resistant prostate cancer, the patient population has become highly heterogeneous, shaped by their prior therapeutic exposures and distinct genomic profiles. The review outlines how landmark trials have integrated poly-ADP ribose polymerase, or PARP, inhibitors for patients with specific DNA repair gene mutations, and radioligand therapy with lutetium-177 PSMA-617 for PSMA-positive metastatic castration-resistant disease. However, because these advanced systemic therapies are successfully extending patient survival, oncologists must become increasingly vigilant in managing treatment-related toxicities. The review emphasizes the active monitoring and management of cardiac events, hematologic toxicities, and the preservation of bone health, which are critical to maintaining quality of life over years of continuous therapy. If you only have time for one paper this week, make it the Elevate trial. This Phase 3 study provides definitive, high-quality evidence that adjuvant Ensartinib dramatically reduces the risk of disease recurrence by 80% in patients with resected ALK-positive non-small cell lung cancer, establishing a clear new benchmark for targeted therapy in the early-stage setting. Here are the key takeaways from This Week in Oncology. First, in completely resected stage 1B to 3B ALK-positive non-small cell lung cancer, adjuvant Ensartinib for 24 months significantly improves disease-free survival compared to placebo, reducing the risk of recurrence or death by 80%, though clinicians must monitor for common toxicities like rash. Second, for patients with gastric cancer and limited peritoneal metastases, adding gastrectomy, cytoreductive surgery, and HIPEC to systemic therapy provides no survival benefit, but dramatically increases serious adverse events and treatment-related mortality. Third, in highly selected patients with medically refractory, lung-limited stage 4 non-small cell lung cancer experiencing respiratory failure, lung transplantation utilizing specialized surgical techniques may offer excellent early survival compared to medical management alone. And finally, the management of advanced prostate cancer continues to shift toward earlier personalized use of androgen receptor pathway inhibitors, PIRP inhibitors, and radioligand therapies, necessitating a heightened clinical focus on long-term cardiac, hematologic, and bone toxicities. That's your roundup for This Week in Oncology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. One more note before you go. Only 4 new papers of note met the bar since the last update. A quieter stretch for new literature. Still worth revisiting from recent updates. Perioperative systemic therapy versus surgery alone for resectable colorectal peritoneal-only metastases. Cairo 6. A randomized, open-label, Phase 3 trial in The Lancet. Oncology, and targeting homologous recombination deficiency with intensified chemotherapy versus standard chemotherapy, followed by olaparib in stage 3 breast cancer, Subito, an open-label, randomized, controlled, Phase 3 trial in The Lancet. Oncology. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence which can make mistakes. Always review the original source materials.